be taking you through GTDs. Our facilitator is Dr. Odongo. So gestational trophoblastic diseases refers to a spectrum of interrelated diseases resulting from the abnormal proliferation of trophoblastic epithelium of the placenta. So it's derived mostly from fetal tissue, which is usually composed of cytotrophoblast and cytotrophoblast, except for subgroups of gestational trophoblastic neoplasia known as placental site trophoblastic tumor, which originates from the intermediate trophoblastic cells. So this is a table showing the different types of trophoblastic cells. So we have the cytotrophoblast, which forms the inner layer. Then we have syncytotrophoblast, which forms the outer layer, and the intermediate trophoblast, which is located at the implantation site and forms part of the and functions to anchor the placenta during implantation. So GTDs comprises of a group of benign non-neoplastic lesions, including the placental site nodule, exaggerated placental site, and H-mole. So for the gestational trophoblastic neoplasias, these are tumors with potential for local invasion and metastasis, and include the following four: CHORIOCARCINOMAs, placental site trophoblastic tumors, epithelioid trophoblastic tumors, and invasive moles. So this is just a repetition of what I've said, the classification. So I'm going to start with H-mole. So these are cystic swellings of the chorionic villi associated with variable trophoblastic proliferation. They're usually due to abnormal fertilization and can occur at any age, but they occur mainly during the active reproductive age. There are two main types. We have the partial and complete moles. For this, the HCG is usually raised and it may precede a choriocarcinoma. So for the epidemiology, it's more frequent in the South.
Ronald?
Okay.
Does the partial mole always precede chorio, or is the complete mole from your previous slide? Because maybe you'll discuss it later, but many times the risk of partial mole becoming persistent is less than 5%, as opposed to complete moles, which is around 15 to 20%.
Okay, thank you for the correction.
Yeah, but anyway, let's just, maybe you've captured it in the subsequent slide. I could be jumping the gun. Okay.
Okay. So for the epidemiology, it's usually frequent. It's more frequent in the Southeast Asia, India, and Africa, and it's rare in European and North American populations. The incidence is usually in Philippines, where it's present in one out of about 80 pregnancies. The lowest incidence is in Europe and North America, where it's about 1 in every 2,000 pregnancies. So it's more frequent in the extreme classes of ages, usually under the ones under 20 and the ones over 40. And the risk may be more than 100 times greater for those over 50 years of age. I was unable to get the epidemiology of GTDs in Kenya. So for the risk factors, one of them is extremes of maternal ages. So below 20 years for teenagers and above that 5 years. Then low socioeconomic status forms part of the risk factors, and it's associated with the nutrition, mainly low protein, low animal fat, low folic acid diets, and low carotene intake. So some certain blood groups also increase the risk for H-moles, including blood group A in a woman with a group O spouse, which is associated with a 10 times higher risk. So blood group AB has the worst prognosis. Then another risk factor is genetics. Then also a history of prior H-mole increases the chances of recurrence. So increase is about 25% in women with more than one previous H-mole. Then also smoking forms part of the risk factors. So for the pathogenesis and pathophysiology, so for the complete mole, it's usually diploid, and 90% occurs from fertilization of an empty ovum by one sperm that now undergoes duplication to form the diploid. Then for the remaining 10%, it results from fertilization of an empty ovum by two sperms to form the diploid nature. So that's for the complete moles. For the partial moles, they're usually either triploid or tetraploid. So majority, about 98%, are usually triploid and occurs from the fertilization of a normal ovum by two sperms. Then the remaining 1 to 2% is usually tetraploid and results from fertilization of a normal ovum by 3 sperms. So this is just a repetition of what I've covered. So for the histological presentation, the complete mole presents with a mass of large edematous villi that are diffusely distributed and typically described as resembling a cluster of grapes in the uterus. Then for the partial moles, the placental tissue is less bulky. There's a few villi, a few enlarged villi with focal distribution. So a fetus may be identified grossly that often has multiple congenital anomalies. So for the clinical presentation, it's prevalent among teenage and elderly patients with high parity. So the patient may give a history of amenorrhea for about 8 to 12 weeks with initial features suggestive of normal pregnancy, but subsequently presents with the following manifestations. So the patient can present with vaginal bleeding, which can mimic an incomplete or threatened abortion. So the blood may be mixed with a gelatinous fluid from ruptured cysts, giving the appearance of the discharge white current, giving the discharge the appearance of white current in red jelly, white current in red current juice. Another presentation may be a varying degree of low abdominal pain, which may be due to overstretching of the uterus from the growth of the H-mole, concealed hemorrhages, perforation of the uterus, which is usually rare and it's mainly by invasive moles, can be due to infections or uterine contractions in an attempt to expel out the contents. So for the constitutional symptoms, the patient may also present with vomiting of pregnancy, which might become excessive to the stage of hyperemesis, and this is usually associated with excessive chorionic gonadotropin. The patient may also present with breathlessness due to embolization of the trophoblastic cells. They may also present with thyrotoxic features of tremors or tachycardia, and this is also associated with the increased chorionic thyrotropin. The patient may also present with expansion of the grape-like vesicles vaginally, but there's usually no history of quickening. So the features suggestive of early months of pregnancy are usually evident, although the patient might look ill than can be accounted for. So they may also present with pallor, which is unusually out of proportion to the visible blood loss. And this may be associated with concealed hemorrhage. Then some may also present with features of preeclampsia, including hypertension, edema, proteinuria, and rarely convulsions might be seen. So the commonest sites of metastasis for H-moles include the lung, brain, kidneys, and the liver. So if metastases do occur, At the time of presentation, the patient will present with the symptoms related to the site of metastasis. So
you have the percentages of metastasis, 80%,
no,
20, 30.
I was not able to get the percentages.
I think the commonest site is still lung, then liver, then vagina, and then brain. I'll get the percentages as we continue. Just carry on. Okay.
So purple or blue-black papules might be seen in the lower genital tract when metastases occur there. Then they may also present with abdominal tenderness if liver or GIT metastases do occur. So the classical features of a complete HMOL include PV bleeding, low abdominal pain, like emesis gravidarum, severe anemia, passage of hydropic villi. The patient may present with distended uterus inconsistent with the gestational age, hyperthyroidism due to thyroid hyperstimulation by HCG. Then they may also present with preeclampsia and also markedly elevated HCG, more than 100,000 milli-international units per ml. Then on ultrasound, we see a small stem appearance, which, okay. Then for the partial mole in history, the patient might present with vaginal bleeding, and it's usually diagnosed as missed or incomplete abortion. So an examination, it might be, the uterus is usually small or equal to the gestational age. So for the diagnostic part, usually begins with the taking of a good history, and then it's usually followed by a good physical exam in the patient. So for the investigations, for the laboratory investigations, you can start by taking the beta HCG levels, then for which I've already mentioned. For the complete male, they're usually markedly elevated and can be greater than 100,000. Although for some cases, some molar pregnancies might present with normal HCG levels. You also need to do a complete blood count. As I already mentioned, the patient might present with anemia. Also, a coagulopathy could be present. Can also do the clotting function test. Then in cases of metastases to the organs I mentioned, you need to do liver function tests, UECs. You also need to do a thyroid function test because some patients might present with symptoms of hyperthyroidism, and also serum inhibin A and activin A, which have been shown to be 7 to 10-fold higher in molar pregnancies when compared to normal pregnancies at the same gestational age. For the imaging, the first one will be the pelvic ultrasound, and this is usually the appearance of a complete mole in ultrasound. It has a classical snowstorm pattern, which represents the hydropic chorionic villi. Then for the partial mole, focal sonographic cystic changes or hydropic changes in the placenta might be seen. Then an X-ray might also be done to look for metastases or lung involvement. MRI and CT scans may also be done to check for metastases to various organs. So for the management, we'll start with the medical supportive care to cater for the presenting symptoms such as anemia, dehydration, hyperthyroidism, and hypertension. Then for the definitive care, it's usually surgical. So the first one, suction curettage of the uterus is usually done using a large cannula with oxytocin or prostaglandin infusion. So the oxytocin is usually used to prevent hemorrhage. Then after the curettage, it's necessary to send tissue for histological evaluation Then after the procedure, you might put the patient on hormonal contraception for about 6 months. Then other than suction curettage, you might also do hysterectomy. It is usually associated with a markedly decreased rate of malignancy compared to suction curettage. So this is a pictorial.
Yeah, Dr. Kibet.
Yes.
The previous slide, the last point, you need to qualify it further so that when you graduate, you don't come out knowing or thinking that all patients with molar pregnancy should undergo hysterectomy.
Okay.
There is a criteria for patients that undergo hysterectomy for molar pregnancy, and this include if they have achieved desired family size, you may consider a hysterectomy. Or if there is bleeding like a river, they call it torrential bleeding, then you may consider hysterectomy, because this is a more sensitive disease, because we are still dealing with molar pregnancy. So unless they really achieve desired family size, you don't hysterectomize them routinely. Carry on.
Okay, thank you. So in some patients, after the management, you can give prophylactic chemotherapy. So 85% of patients usually undergo spontaneous remission. So it is usually used with advantages in the following circumstances, one of which is HCG levels fail to become normal after 4 to 6 weeks. Then there is re-elevation of HCG more than 20,000 milli-international units per ml at 4 to 6 weeks after management. Then there is evidence of metastasis irrespective of the HCG level. And also in cases where the malignant sequelae is higher as judged by the risk factors, or where proper follow-up facilities are unavailable. So for the chemotherapy, the drugs usually use methotrexate, dactinomycin, cyclophosphamide, etoposide, and 5-fluorouracil.
But again, will you go through the WHO prognostication before you choose the chemotherapy? Because like you just put a slide on prophylactic chemo, which is also rarely used, because when they're doing chemo, you give with intention to treat. And this is guided by the WHO prognostication, risk prognostication score. It must be in your slides ahead or something.
Yeah, I have the prognostic.
It's okay. And that's fine. Yeah, that's fine then, because occasionally there are some patients you put on treatment, and you already mentioned that HCG levels fails to normalize, re-elevation, evidence of metastasis, but you need to do WHO scoring to guide you on what kind of treatment you will give. For our setting, we don't use the last three. We use mainly methotrexate or actinomycin D as for the single agent kind of treatment. But I think it will become clearer when you present the next couple of slides.
Okay, thank you. So this is how the regimen is usually given, methotrexate and actinomycin D. You can go through them during your own time. And so these are some of the complications associated with molar pregnancies. You can have thecal lutein cyst, pregnancy-induced hypertension, hyperthyroidism, respiratory distress, coagulation failure, hyperemesis, and uterine perforation. So for the gestational trophoblastic neoplasia, these are malignant neoplasms. As you already indicated, most usually follow a complete mole. Then the histologic types, as I already mentioned, include the invasive mole, choriocarcinoma, placental site trophoblastic tumor, epithelioid trophoblastic tumor. So for the first two, the invasive mole and choriocarcinoma are usually characterized by high levels of HCG, while the last two are typically associated with low HCG levels. So the main risk
What are they
factors,
associated with? Maybe just dispense with it now. What are they associated with?
they have low HCG levels compared to
So what would you
invasive
look
mode.
at? What would you look at? Which tumor marker? And I know someone knows. Just shout it out. What is HPL? Yeah, because I thought you tie this with the introductory slide.
Human
You know,
placental lactogen.
Yeah, thank you. Yeah, you talked about the intermediate trophoblast, the chorion frondosum, and all that. So the intermediate trophoblasts mainly produce HPL, and PSTT is thought to arise, not thought to, well, it arises from intermediate trophoblast, and they elaborate human placental lactogen, also known as human what? Somatomamotrophin or something like that, placental growth hormone.
Okay.
Carry on, Dr. Kibet.
Okay, so for the major risk factors, they include premolar pregnancy, advanced maternal age more than 40 years, the race which include Asian and the American Indian as ancestry, which are associated with increased risk. So, and invasive mole, as you already mentioned, they develop after molar pregnancy and is characterized by the presence of edematous chorionic villi with trophoblastic proliferation invading the myometrium. So the risk features for postmolar GTN include pre-evacuation uterine size greater than dates, HCG levels more than 100,000, then a bilateral ovarian enlargement caused by excess HCG stimulation, then a previous cesarean section. So some invasive moles usually remain localized to the uterus, while others are metastatic. But deep myometrial invasion may occur up to the level of the uterine serosa. Uterine rupture and severe intraperitoneal hemorrhage may occur if deep myometrial invasion is left untreated. Metastases of invasive moles usually spread hematogenously, mainly to the lungs and the vagina. Then for choriocarcinoma, they consist mainly of invasive, highly vascular anaplastic trophoblastic tissue made up of cytotrophoblasts and syncytotrophoblasts, but now without the villi. 50% of choriocarcinomas usually follow H-moles, which you mentioned the complete H-moles. Then 25% follow abortions, and 25% follow normal pregnancies. So the uterine cavity is usually filled by soft yellow white tumor. Extensive areas of necrosis, hemorrhages, and cysts may be seen. So on histological examination, you'll see anaplastic cytotrophoblasts and syncytotrophoblasts, no chorionic villi are seen. As I already mentioned, HCG are usually produced in large amounts, so it can be used to monitor progression. And choriocarcinoma is usually very responsive to chemotherapy. So it is the most aggressive type of the GTNs, and it is characterized by early vascular invasion and widespread metastases. So clinical presentation will depend on the extent of disease and location of metastases. So metastases occur mainly to the lungs, vagina, the brain, liver, and the kidneys. For the placental site trophoblastic tumor, they are malignant and develop from extravillous intermediate trophoblasts. They're usually diploid and monomorphic. So they occur most commonly after non-molar abortion or pregnancies, although it can occur after a molar gestation. So a key difference with the other two is that human placental lactogen is usually used to monitor the placental site trophoblastic tumor, and it's associated with less vascular invasion, necrosis, and hemorrhage compared to choriocarcinomas. Most tend to remain localized in the uterus for long periods before metastasis occurs to regional lymph nodes or other metastatic sites. So treatment for this is mostly hysterectomy. Then for the epithelioid trophoblastic tumor, it's a rare variant of PSTT. It develops from neoplastic transformation of the chorionic type extravillous trophoblast. They present as discrete hemorrhagic solid and cystic lesions that is located either in the fundus, the lower uterine segment, or in the endocervix. It forms tumor nodules in the myometrium, and the clinical behavior is similar to that of PSTT. So diagnosis is usually late in the course of disease due to the slow growth, paucity of symptoms, and the low or absent HCG production. So generally for all these gestational trophoblastic tumors, the risk of metastasis varies depending on the histologic type and the duration of the disease.
Yeah, that's the slide I was referring to. Yeah, okay. About the commonest site of metastasis, which is the lung. Okay. That's why the lung scores very low, even on the WHO score, 80% pulmonary. Carry on.
So these are the commonest sites. The lung invasion is about 80%, followed by vaginal. Then CNS invasion at about 10%. Then hepatic at 10%. Other sites include the kidneys, the GIT, and the spleen. So for the pretreatment,
Dr. Kibet, yes? The previous slide you missed, you mentioned a very important point that you've put there, that we rarely see CNS involvement without chest involvement.
Okay.
Yeah, and that is why the indication for imaging of the CNS is a positive chest imaging. If there's nothing in the chest, there's no need of doing a brain imaging.
Okay. So, okay, so for the pretreatment evaluation, so prior to initiation of treatment, you need to assess stage and ability to tolerate chemotherapy. So for the assessment, you need to do a complete history, physical exam. Then you need to do baseline laboratory investigations, so which include the serum, HCG, a complete blood count, liver function tests, renal function tests, and thyroid function tests. Also for the radiological investigations, you can do a pelvic ultrasound. This is to rule out pregnancy, and also it allows you to measure the uterine size and volume, and to evaluate the degree of pelvic spread. You can also do a chest radiograph. As we've already seen, the lung is the commonest site of metastasis of these tumors.
I'm wondering, that bullet about pelvic ultrasound, it's not really clear. I think the reason why you're doing a scan, rule out, ensure that the patient is not pregnant. This patient is already pregnant, only that it's a molar pregnancy.
Okay.
I don't know what that really means. But of course, the other bits are okay. You want to obtain the measurement of the uterus, the volume, the size of nerves, size of tumor in the uterus, and the chest radiograph. Yeah. The patient is already pregnant, only that it's smaller. Or you're trying to ascertain there is no normal pregnancy, maybe.
Okay. I think you can use to rule out the presence of a fetus for the partial males.
Okay. Okay.
So prior to initiation of treatment, you need to stage and also do risk assessment. So for GTN patients, We use a combination of the FIGO staging system and also the WHO prognostic scoring system. So the WHO prognostic scoring system usually takes into account about 8 risk factors that have been shown to predict the potential for development of resistance to single agent chemotherapy with methotrexate and actinomycin D. So these are some of the risk factors which are usually used for scoring. So one of them is age. The second one is antecedent pregnancy, interval from the last pregnancy. The treatment serum HCG.
Dr. Kibet, the first point is very important. When you are writing, you write the stage in Roman numerals, and then you put a colon, and then you write the Arabic numeral. This is how we record in our notes. Let us all take note, because I realize some people don't even write this, but this helps us know the stage of disease and the score. I didn't see where you talked about the stage. By stage 1, of course, localized to the uterus. Oh, there it is. Okay, I can see it. You moved so fast. Pull down the pace. You're moving too fast.
Okay. So I wanted to mention the risk factors first.
It's okay. It's okay. It's okay. You know, that's just a regular rhythm. Cool down the pace.
Okay. Okay, so this is how the risk factors are scored. And kindly let me move to a slide that has shown just the risk factors, the WHO risk factors. So this is the era.
Yeah.
So you can see age is scored out of 1, then antecedent pregnancy up to 2, then interval in months from the previous pregnancy, interval in months. So interval, time between end of antecedent pregnancy and the initiation of chemotherapy, it's scored out of 3. Then beta HCG level to treatment, beta HCG level is scored out of 3 also. Then ABO blood group is scored.
We no longer use it. Ronald?
Okay. Yes?
I don't know the reference you got this one from, but I think blood group was dropped in 2012.
Okay.
How old is this reference?
I'm not sure, I just got it somewhere.
Maybe it was put back when I was still asleep. Remember that story of guys fell asleep when someone planted tears?
I'll confirm.
Yeah, because I think it was dropped in 2012.
I think
on the same note, Dr. Odongo.
Yeah.
Hello.
Yes, Maureen.
With the current score, we don't have a score of 3, so it's either 0. The score.
Yeah, it's 0124.
Yes, 0124.
Yeah, that's what I'm thinking. That reference is.
Okay. I think that was an old one. This one that I'm displaying is.
Yeah, this is now the latest one. Yeah, this is the correct one. So maybe tell the students to expunge it from their memories. It's going to be difficult because they've already seen it. They have to unring the bell.
Okay, I'll delete that slide before sharing the slides.
Yeah, to AKE.
Okay. So, under the new one, so age is scored as either 0 out of 0 or 1. Then antecedent pregnancy up to 2. Then interval in months is from 0 to 4. You should note that under this score, there is no 3. It's either 0, 1, 2, or 4. So for the pretreatment, serum HCG levels up to 4. Largest tumor size is scored up to 2. Then the site of metastasis, depending on the site, the lung is scored 0. The spleen or kidney scored 1. GI tract scored 2. Then the brain or liver scored 4. Then the number of metastases, there's no score of 0. If the number is between 1 to 4, the score is 1. 5 to 8 the score is 2. Then more than 8 sites of metastasis is scored 4. Then prior failed chemotherapy is scored is either 2 or 4, 2 being a single failed therapy due to failed single drug therapy, and also scored 4 for failed multi-drug therapy. So, for the use, the use of the WHO prognostic scoring system is more predictive of the clinical outcome. So a score of 0 to 6 usually suggests a low risk resistance to single agent chemotherapy. Then a score of between 7 and 12 indicates a high risk of resistance to monotherapy and requires combination chemotherapy. Then a score of more than 12 or more is considered ultra high risk and particularly associated with non-molar antecedent pregnancy, brain metastases, and failed prior multi-agent chemotherapy. So the benefit of using the modified WHO scoring, WHO's prognostic scoring system applies primarily to FIGO stages 2 and 3, since essentially all patients with FIGO stage 1, GTN and low risk, and more than 90% achieve remission with single agent chemotherapy. In addition, FIGO stage 4 diseases have high risk scores, which indicates probable resistance to single agent chemotherapy and the need for primary treatment with multi-agent chemotherapy to optimize outcomes. So,
yeah, that's true. That's a very good observation. That the benefit of this scoring is mainly stages 2 and 3. There is a new. This has been revised further. I think 2018, whereby we now have a score of 0 to 4 as low risk, because we've now shown that even those who had a score of 5 to 6 ended up requiring multiple agent chemotherapy. So 0 to 4 as low risk, 4 and above to 12 as high risk, and above that is ultra high risk.
I'm sorry, could you please repeat the scoring?
Yeah, I hope I'm repeating the right thing. From FIGO 2018, because this is from the studies that showed that those patients who scored 5 and 6, they actually had resistance to single agent. They ended up requiring multiple agent treatment. So they're initially called intermediate risk. So this has since been revised such that the low risk is 0 to 4. And depending on whom you're answering that question to, because you could be answering that question to a generalist who may actually not understand what we are talking about. I don't know, it depends on which angle you are approaching it from, but if you're talking to a gynae-onco, then they should be able to understand that 5 to 6 scores have now moved to high risk disease. I hope I've explained it.
Yes, you have.
FIGO 2018, we can confirm that. Okay.
So for the last part, so for the treatment, so the treatment depends on the availability of serum beta HCG assays. So the management decisions depend on whether the patient is either low risk, high risk, or the ultra high risk group. So for the low risk patients, usually use a single agent chemotherapy, either methotrexate or actinomycin D. Then for the high risk patients, we usually use multi-agent chemotherapy, IMACO, or surgery. So
surgery is only in selected cases. Again, it's only in selected cases.
Okay.
Like I said initially, maybe it has to be discussed in a tumor board before you decide on surgery on these patients.
Okay, so these are some of the indications for surgery.
These are the ones when there's drug resistance, I've already mentioned control and controllable hemorrhage. I've mentioned completed childbearing. And if you are able to resect a solitary metastasis, people have done lobectomies, craniotomies for solitary metastasis that are chemoresistant.
Okay, thank you. So after treatment,
now ultra high risk, which I mentioned, treatment of ultra high risk, we know ultra high risk also is resistant to EMACO. So you go to other agents straight on. You either try MIEP or TETP. So if a patient has an ultra high risk core 13, even in our unit, we are changing that protocol from ultra high risk. We actually prefer MIEP or TETP, TPTE. But does it matter? TETP, TPT, they still follow each other. Yeah.
Okay.
And one more thing I wanted to mention, induction chemotherapy for the ultra high risk disease, because of the risk of tumor lysis syndrome. Some of them go down if you just put them on EMACO or MIEP upfront. So we do slow induction with the etoposide, low dose etoposide and cisplatin before you now embark on EMACO. I hope everybody's understanding the words that are coming out of my mouth. I can't see you guys. So I don't know if you're understanding or Wengine is that we are together, I hope.
We are.
Yes, we are.
We are.
Okay, asanteni. Yeah.
So, so after treatment, follow-up mainly is usually beta HCG weekly until normal for 3 consecutive weeks, then monthly for about 12 months. Then after that, you ensure reliable hormonal contraception for about 1 year. So that's all under my presentation. So unless there are any questions.
Yeah, it's a good summary. And I speak like my pastor, he who has an ear, let him hear. The Spirit says to the churches, this is not the Spirit now. This is the flesh speaking. Oncology. I think there are some pertinent critical steps that we should know that you'll be put to task on. For example, how do you do suction curettage? Again, this is not leakage. This one we will ask. The steps to suction curettage. I know you mentioned it earlier, and you'll be given a scenario that this is a patient who came with, she has uterus size bigger than dates. She's passing vesicles. What is your most likely diagnosis? Then you say, of course, a molar pregnancy. How would you investigate her? Then you say, of course, I'll do beta HCG. You'll do pelvic ultrasound scan. What would you see? Snowstorm appearance. How would you proceed? That's usually the next question. Then you say you do suction curettage. Then the question will be, how do you do suction curettage? Almost remember to say informed consent, prepare the patient properly, obtain informed consent, prepare the patient properly, wide bore IV access, and then prepare blood, GXM typing, take the patient to theater, place in lithotomy, start on oxytocin, use the widest possible Kaman's cannula, oxytocin concurrently with the suction as you proceed. You know, those steps, I think it is good for you to know, because we know you know about what's a trisomy in molar, in partial mole, what is dispermy. Anyone can answer that. But since you are a clinician on the clinical arena, those pertinent issues are the ones you should know. And that question will be asked. And I say again, verily, verily, I say unto thee, you'll be asked that question. So how many have we said you'll be asked so far? Samaine?
4.
Yeah, there was one about cervical cancer.
Yes.
Yeah. He who has an ear, let him hear what the spirit, no, what the flesh is speaking about oncology. Any questions? Because we need to move.
Doc, I was asking,
yeah,
for how long do you give the induction chemo when you're
2 cycles.
When you prepare
every
for
2
2 cycles?
Yeah.
Okay.
In fact, it's every week. Is it every 2 or every week? I think it's every week or 2 cycles. And then you now go to the real, not the real, but the full dose of combined chemotherapy. You can start with cisplatin 20 milligrams per square meters and a toposide 100 milligrams per square meters.
Okay.
And then after that, now give the Emaco. This for the ultra high risk disease, mainly because we've noticed that some of them just die when you start on full combined chemotherapy.
So thank you.
If there's no question, Dr. Brian Bett was to present on the use of chemotherapy in gynecological malignancies. We are trying to arrange for Wednesday morning. Is it possible? Wednesday 8, or you'll be in classes already? You have other classes arranged?
Wednesday morning, we love
oh yeah, you have Journal Club, yeah.
We have a program on Wednesday morning. So.
Yeah, I remember, yeah. I don't know. Anyway, let me organize it between you and Tamaini and Bet. We see when else we can hold that class. The next one is on epithelial ovarian tumors or what? Chance.
The next one.
Which other class were you to have with me?
Okay, let me check. I'll inform you.
Anyway, just check. We can discuss it outside this forum.
Yeah.
Otherwise, asanteni sana. Bye bye, everybody.
Thanks so much, Doc, for your time.
Bye. Thank you.
Bye.
Bye.
Bye.